Let's look at a basic neuromuscular treatment with some myofascial work to her left shoulder. So I felt a little resistance to movement in her left shoulder, and we want to take a closer look. Yeah, so again, gentle, just pretty superficial, broad contacts, moving the oil around, getting a sense of the lay of the land. So the first thing that kind of is popping up at me is her lower trapezius area right here. Some people, if they were just chiropractically inclined, might think of this as a rib being posterior, but we like to broaden the lens and not just think of bones as floating in empty space, but surrounded and supported and really given their form by fascia, soft tissue, muscle, nerve, tendon, ligament, and sinew, all of those things. So nicely, her upper trap tone is pretty good. It doesn't feel real tight and knotty. And so here's her scapula, the medial border, the inferior angle, the lateral border, which puts her glenohumeral joint right here. And let's just start. Let's just get into it. Thinking about that lower trapezius as originating down here on T12. And because this is not a deep muscle and we're not doing super deep work, I'm sitting and I'm using my fingertips in just kind of a gentle pulling motion. For one thing, I don't have to get up. Makes things a little easier for me. For another thing, it's nice on your hands if you're not always using the same part of your hand to do the strokes. So, so it's like fingertip, thumb with the reinforce on the other hand, heel of the hand with a little bit of inferior pressure on the scapula, giving her muscles a different look, but staying with the same rhythm and cadence so that there's no surprises for her body, and also staying with the same depth for the same reason. And we don't want to generate alarm bells and bring up fright in the patient's nervous system, even especially unconsciously, because then they're going to guard. So the idea is that by the end of the session, their guard is all the way down. And them being guarded is not their fault. It's not a problem. It's natural. Mm-hmm. So here we're coming up against a little more restriction right here. And you see this a lot where the lower trap crosses over the scapular border. And so it's just a matter of gently mobilizing the fascia. No big deal. So you can see I'm really not using pressure. Like there's no need for me to put my elbow in there. Just trying to get it moving. And you can see I'm using my left hand to create just the tiniest little bit of movement of the scapula. And as the scapula moves, using my thumb and the palm of my other hand to induce corresponding movement in the other tissues. Now you can do this together. So both hands kind of inducing inferior movement, lateral movement like this, or you can work your hands in opposition like this. Either way, both are good. The whole point again is like circulation, neurological awareness, bringing the patient's body and mind into a better communication so that the brain can make better decisions about posture and movement, levels of tone, and how much activity is being used in each muscle. So it's kind of naturally now transitioning to more the lateral border of the scapula, easy strokes with the palm and the heel of my right hand. Again, that rhythm is pretty steady, and we're going to change direction now and stroke inferior to superior. Feeling a little more resistance and restriction here in the infraspinatus, teres minor, and lat. So don't forget the latissimus dorsi. It's a shoulder muscle, and the bulk of it is really right here. So we see her lat, her teres minor, her infraspinatus. You will often see trigger points in the infraspinous fossa. A lot of times they're going to refer distally, sometimes even as far as the wrist and hand. And here is a place where I find that just some gentle sustained pressure can be really, really helpful on those trigger points. And so, if it doesn't give away right away, that doesn't mean you're not pressing hard enough. If it doesn't soften immediately, the idea isn't necessarily to press harder. Sometimes the idea is, well, maybe there's too much pressure. Maybe you're not at the right depth. So actually at Sitka just now, I let go a little bit, and instead of using static pressure, I started mobilizing. I guess you'd call this lateral to medial, and that was when it started to let go. So now sitting and facing the foot of the table, we're going to position her arm draped over the knee just like this. So there's nice little bit of abduction of the shoulder. The weight of the arm is totally on me. There's a few different nice things about this. Number one, it gives me a little more access to the tricep and infraspinous and the posterior deltoid here. For another thing, if she starts to tighten up in her shoulder, I'm going to feel it immediately. I'm going to get immediate feedback. And also with the position of my leg, I can create a little bit of traction, just a tiny little bit. Just by adducting my knee, I just get a little bit of traction here, and I'm going to support that here. So let's demonstrate just a little bit of shoulder traction here. Opening the glenohumeral joint, getting a stretch on the rotator cuff tendons, and as I release it, you're going to see just how little stretch it takes. It's like almost nothing. Here it is, gentle stretch. Here it is, relaxed. If we focus here on the scapula, we can see it's coming out a tiny bit and then retracting. So we can do a static stretch or we can do a gentle rhythmic stretch. But the idea is tractioning the scapula, tractioning the glenohumeral joint, and always in almost 100% of our patients, and especially with anybody with an upper body, a shoulder, or a neck problem, getting movement between the scapula and the rib cage is so crucial. If I turn and face her now, I'm cradling the elbow with my lateral hand, and I can get a little more traction like this here. So the heel of my hand holding the scapula in place while my other hand tractions her arm outward. And because of the grip that I have on the distal biceps and the triceps, this stretch and this mobilization is not just the joint, it's the whole sleeve of fascia of the entire upper arm. And I love this one. I do this all the time. Taking this tractioning hand down, distal to the elbow. I've got a grip, not super tight, but I've got a grip on her forearm. My upper hand here at the scapula is doing the same thing. And they're like pulling apart and relaxing. None of this is jarring. None of this is sudden. We want to work smoothly with fascia. Give us a nice sustained stretch. I just felt her breathe into it. So let's honor that and let her really feel this nice stretch. So now with my right hand, I'm distal to the wrist. And with little tiny bits of movement, I can rotate, supinate, pronate, flex, and extend her wrist. And really try and feel where is that tension. With all of our phone and computer use, people carry a lot of attention around in their wrists and forearms. And while you can't make them stop using their phone, you can give their forearms a nice mobilization and stretch. So with this upper hand now, I'm going to come down to the elbow and give her arm a little traction while I give these wrist extensors a little squeeze. Just a little TLC. And we'll put that arm back. So we just gave a nice treatment from T12 all the way out to fingers in just a few minutes, and focusing on the lower trap and these lines that follow the lower trap, the infraspinatus, the lat, and then down the arm lines as well. Let's not forget the rhomboid. So we're going to work now from spine to medial border of scapula, right? So these are easy thumb strokes. And I'm supporting with my other hand as my thumb strokes medial to lateral. My other hand is giving it just like a little bit of movement. If I took my right hand away, this is what you would see. Just a little bit of pressure. So just kind of remember moving things together. We want integrated movement, not isolated movement. We want things to be able to move in relation to each other, and we want her brain to be able to recognize what it feels like when these things move together. Feeling now a little more stuff in this upper part of the rhomboid, and we're going to address this more when we do her neck. So for now, just making a mental note and giving it some gentle strokes, medial to lateral from spinous process to medial border of the scapula and over the medial border, changing my hand position so that no part of my hand gets too tired. And again, trying to think about that integrated movement. Okay, let's get you turned over.